So welcome, guys. Thank you again, Dr. Yuri's, Dr. Ed, for having me on the webinar. I love doing these with you guys, and this is part 3, or the third one of our 4-part series. And we really talked about focusing on the cervical spine this year throughout 2020. So I just want to start by reviewing what we talked about on the previous general webinars. So the very first one that we did, we looked at the cervical research. Basically what I had done there was I broke down some of the research behind CBP and the dental rolls, and we talked about the ideal cervical model that was established by CBP and why I believe that's the best model for subluxation-based corrective chiropractors to use. So we looked at what the ideal was. We talked about spines deviating away from normal. And then we talked or showed you the randomized clinical control trials on the cervical dental roll, discussing the reestablishment of that curve or improvement of the cervical spine using the cervical dental roll. And I showed you guys how to measure anterior head translation on x-rays, and we looked at how to measure the total cervical curve. Right? And the purpose of showing you guys the research was to show you that, you know, if we're doing curve correction, if we're doing corrective chiropractic care in our office in a subluxation-based model, my personal and professional opinion is that we should be using dental roll products. And I put a tagline here saying, is the dental roll truly superior in correction potential? And that is in relationship to other rolls out there, because you have big companies that are marketing these different corrective orthotics for the cervical spine, and they talk about curve correction, but the reality is 90%, if not more, don't have any research, real research to support the claims that they make about cervical curve correction. And so that often really kind of bugs me. So last Thursday I said, well, you know what I'm going to do is I'm going to x-ray myself on the cervical dental roll, and I'm going to x-ray myself on a competing orthotic, cervical curve orthotic, and just because I wanted to see the difference in how what effect it had on my cervical curve. So here's my cervical spine, here's my lateral cervical, 27 degrees. So you see I need a little bit more curve here from C2 to C5, right? And I lay on a small cervical so I can get the peak right up there and try and improve my curve. So here are 2 x-rays of me seconds apart. They're both laying supine on my dental roll table, and then I just flip them so that we can read them as if, you know, you're looking at a lateral cervical x-ray. So here is me on the small cervical dental roll, and here's me on a competing cervical orthotic unit. So my 27-degree curve on the small cervical dental roll goes to 36 degrees. You can see the peak of it right here, kind of pushing in, creating some nice extension and improving that area in my spine where I need more curve. On the competing roll, I get 9 degrees of curve. You can see it here pushing up, right? It's pushing kind of right like that. So my curve goes from 27 degrees to 9 degrees. So again, the main reason I did this was just to really state the fact that I buy into these products because I know the research is there, and I'm helping support chiropractors that are practicing in that subluxation-based corrective model. And some of the money that is spent on dental rolls is going to publish research so that we can continue to do the things that we do, right? So that we can continue to take x-rays on our patients, so that we can continue to practice in this subluxation-based model. Because if you're not aware, there truly is a political battle happening in our profession. And in BC right now, the BC Chiropractic Association is working on ripping the x-ray rights away from chiropractors. And in that scenario, chiropractors are only going to be able to take x-rays of red flags, so things like, you know, tumors, infections, and fractures. So there's a huge battle right now from the metapractors, you know, the pain-based faction of our profession, trying to take away the use of subluxation and the use of routine spinal radiographs. So if you're not familiar with the article that just came out from Pierre Cote, you probably do know that name. He is, but anyways, he's involved with the British Columbia Chiropractic Association, and they're trying to reduce or remove rights for x-rays right now. And so we have to work very hard to rebut this and prevent this problem from obviously spreading across the rest of Canada. And so the chiropractors who are writing articles right now and pushing research to rebut this, and in the battles on the forefronts, are the Deed Harrisons and the Paul Oakleys, Chris Kolokas, Jeb McAveenys. And these are all chiropractors that are involved in the research and the funding for dental rolls. So, you know, when you support those products, you support the chiropractors who support you. So very important to keep that in mind. All right, last time, June 23rd. So we talked about using dental rolls, right? When they should be used. And then furthermore, we went into discussing, okay, so how do we estimate curve correction on a patient that can use a cervical dental roll? So we talked about the pizza angle. So I will just briefly in a few moments here go over that measurement again, because it's really important to understand that. Then we mentioned the difference between a cervical primary problem, so when do we use a cervical dental roll, versus when are we using a thoracic dental roll because the patient has a primary subluxation, aka a thoracic hyperkyphotic problem. So on the last webinar, I showed you guys how to determine if it's a thoracic subluxation, but I never showed you any cases where the cervical outcome, so looking at the cervical curve improvement via using thoracic orthotics. So today what I want to show you guys is, okay, we determined that this patient should use a thoracic dental roll. I'll show you the placement and how to use those thoracic dental rolls, but I want to show you the cervical curve correction after using those thoracic dental rolls, because it's staggering. You can get amazing cervical curve results when you're choosing that proper orthotic product for the patient at home, okay? So let's just go back last time through the pizza angle calculation, because I know it's complicated, but it is very valuable to use in practice. So if you guys remember this slide, this is how you calculate or estimate how much curve is appropriate for a patient. So it's called the posterior tangent sternal incident angle. So posterior tangent sternal incidence angle. And basically what it is, it's an indirect calculation of our thoracic inlet. So I can just draw around the collarbones here. This is your thoracic inlet. The larger this oval, circle, whatever you want to call it, the more space you have for a cervical curve. The smaller or the shallower it is, the straighter the patient's neck, because they don't have enough room to push a curve into the neck. If they had a really deep curve, it would basically jam up the trachea, the windpipe, the esophagus, and so on and so forth. So this pizza angle is an indirect measurement of how much patient or how much curve that patient can have based on this right here, which is our thoracic inlet. Okay, so the ideal or normal would be 73 degrees. But a lot of patients are going to fall right here between 50 and 75 degrees, right? So on the shallower end. So these are patients that generally have a loss of cervical curve. And so these are going to be our cervical dental roll candidates, but they're not all going to have the same curve correction potential. So I gave you guys my estimate last time. I said approximately, if you're running in these degrees of pizza angle, you can expect 10 degrees of curve correction. And then between these degrees, you can expect this kind of curve correction. And this is not exact yet because the formula is not out. I gave you guys this as an estimate. And then Dr. Kwan mentioned his formula, which works fantastic, by the way, which was the pizza angle minus 40 degrees is approximately the curve that you can expect. So if we look 50 here, minus 40 gives you 10 degrees. It works. 65 minus 40 degrees gives us 25 degrees of curve, and so on and so forth. So this is a very good estimate as of right now to measure how much curve is possible for a patient. If the pizza is above 75 degrees, we're thinking thoracic hyperkyphosis, right? And if that pizza angle is above 75 degrees, we're going to be looking at these two measurements, large anterior head translation and the slope of C7 and T1 relative to vertical, right? So if I have a large anterior head translation, a high slope of C7 and T1 relative to vertical, and I have a pizza angle above 75 degrees, your spidey senses should be going off, and you should be assuming that this patient has hyperkyphosis, and you should be giving the patient a thoracic orthotic to lay on, because you will get better overall results with that patient. Okay.
Hey Pascal, can I ask you a question?
Yes, sir. Absolutely.
Can you just review how that pizza angle is measured again?
Yes. Sorry, I went through it. I was going to show you guys, and I got too excited and forgot to show it. Okay, so we put a dot right here at the base of T1, so the posterior inferior corner, okay? And you can put another dot right here. So don't worry about this line right now. That's for the slope of T7 and T1, or sorry, C7, T1. We'll show you that after. So I get my two dots, and then I connect them, or I draw what, if you remember from school, they call it George's line. So I draw a tangent, which just means George's line, that runs along the body or the back of T1. So that's kind of like my T1 slope line. Then I find the top of the manubrium sternum, and I put a dot right there. So I would connect the top of T1 and the top of manubrium sternum. That's what this line represents. And then I can just measure the angle between this connecting line and my George's line. So that angle right there, that's the pizza, right? And if you could see it, it kind of shows you that it's kind of measuring this thoracic inlet. So again,
So
it's a line.
if you can't see T1, because
You go to C7.
oftentimes
Yeah, you would go to
C7,
C7.
okay.
Yeah. And then T1 is better, obviously, because it's closer to the thoracic spine. But if it was C7, it would be the same thing. It would just be, oh, sorry, for pizza angle, no, pizza angle has to be off of T1. So if you don't
Okay.
have the pizza angle, Yuri, then we would just use the tangents as an indirect estimate of the thoracic hyperkyphosis. But you could kind of look like if I would do this, let's go to, when we get to 2 more slides, I'll show you what I mean, right? But we
Okay.
could look at the slope of T7, and the more C7 is sloped relative to vertical, the more likely you are to have a curve. So the flatter the pizza angle, the more straight up T1 is going to be. In other words, if I had a very shallow pizza, my T1 would not be sloped like this. It would actually be maybe a slope like in this. It would be very shallow. So I'd have a very small angle, right? And so C7 is going to follow T1's angle pretty closely. So in a perfect world, we can see T1 and we can see the manubrium sternum. And if not, you'd have to just use your best clinical judgment. And there are cases where, you have very thick, broad-shouldered patients and you can't see it. And so then you have to do your best and use clinical judgment. One of the ways that I've also told doctors that they can kind of think about it is the higher my T1. So if I see collarbones, and even though you can't necessarily see the manubrium sternum, we'll say, the higher T1 sits above the collarbones, the more likely they are to have a small pizza angle, right? So the higher my T1, if my T1 is all the way up here, my line has to come down, my pizza is narrower. So if you can't see T1, oftentimes it's because like C7 is sitting way down here. And if C7 is sitting way down and T1 is way down, almost always, Dr. Yuri, they're going to have a very deep pizza angle. Does that make sense?
Okay.
So if you can't see T1 and you can kind of make out collarbones and you see that T1 is kind of hidden inside the collarbones, if you will, you can assume they have a large pizza angle and they're going to have at least a normal cervical curve, if not more cervical curve. Did that answer your
Okay.
question?
Yeah, and are you ever using filters to get T1?
Always.
Always,
Always.
okay.
Yeah. I use a filter, especially not always on my lateral cervicals because I can get it, but then when I do a lateral full spine and then I put the cervical filter on right here so that it can blast through and I can make sure that I can see the T1 and the manubrium sternum. Because oftentimes on the lateral cervical, you can't see this. There's just no way you're going to see it unless you're opening up your collimation a lot. And it's just learned over time of how to take the x-rays and how to position the central beam. I position my central beam a little bit lower on my lateral cervicals. Instead of being maybe C4, my central ray is probably closer to here, so I get better exposure to get this.
Okay.
Okay.
Thank you.
No problem. And I'll show you some examples where the C7 is lower relative to the manubrium sternum on some lateral cervicals here in a couple of x-rays. So large anterior head translation, and here's that example, Dr. Yuri. Here's a perfect example. C7 is low, the collarbones are sitting right about here. My T1, even though I can't see it, if I assumed that my T1 was here and my collarbones are here, I mean, that is a very deep angle. It's almost 90 degrees. Does that make sense? So these are those thick, like, I don't want to call them sausage necks, but those are those very thick, short necks where C7 and T1 are sitting almost behind the manubrium sternum. They have very deep pizza angles, and they're often very more kyphotic or rounded in the shoulders, because of which they're going to have large anterior head carriage just like this. So here's an example above 50 millimeters. This is 72 millimeters of head translation. I would not want to use a cervical dental roll on this patient because they have a lot of rounding in their thoracic spine that's driving that head forward. So if I use the cervical dental roll, I'll probably end up getting a better curve, but the head's going to stay, 50 millimeters forward. So I'm missing a big part of the problem in this case. So here's that C7 T1 tangent to vertical. So if I could not see T1 or the manubrium sternum, this would be another indication of hyperkyphosis, but it's not necessarily an indication of curve correction. this tells me how much kyphosis the patient has. So we would use T1 if we can see it. If not, we use C7. And so this value here, I put a dot at the posterior inferior aspect of T1. I draw my line to vertical straight up. This is the same line behind T1 that I was using for my pizza angle. This value here is an indirect measurement of thoracic kyphosis. A normal kyphosis is 44 degrees. Okay, that's how much rounding should be in the thoracic spine in a perfect case. So if I found that my angle was 26 degrees, I would assume that the patient has a normal thoracic spine. If my value here was less than 26, so if it was, 18, 19, I would assume that they have a flattened thoracic kyphosis. I gave you guys a cutoff last time of 30 degrees. So anything above 30 degrees, you should not give that patient a cervical dental roll. You should assume that it's a thoracic problem, and you would give them a thoracic orthotic to lay on. Now, Dr. Yuri, the question, and I kind of mentioned that you can sort of use this also as an indirect measurement. So let's say I could not see T1 on my x-ray. So I'm going to use C7 tangent to vertical. So here are the dots. I put an inferior dot at C7. I put a top dot at C7. I draw that line behind the body of C7. I take a vertical line and I draw it straight up, okay? I measure this right here, okay? And this value at C7 is a bit shallower. It's measuring 21. So let's say, even though I couldn't see the pizza angle, if I had a value of 21 degrees at C7, it tells me that they probably have a normal kyphosis. They more than likely have a normal pizza angle. I would assume that if my value was close to normal, I would have maximum curve correction. If this value is like 10 degrees, if I measured this value at 10 degrees, I know I likely have a shallower pizza angle. I couldn't tell you what the curve correction would be in that case, but basically the closer this value approximates 0 or smaller values, you're going to have less curve correction. And then the higher the value here, obviously the more curve correction, and the more you approximate 21 degrees, the more likely you are to have a normal cervical curve. And then if you can't see T1, again, the cutoff here is 25 degrees. So anything above 25 degrees at C7 now indicates a kyphosis problem in the thoracic spine. I use a thoracic orthotic, right? So that's kind of your indirect sign of what a curve would be like. The closer you are to 21 at C7, the more likely you are to have a normal curve. A very flattened C7 generally indicates a smaller thoracic inlet, lower PTSIA, less curve correction possible, but I can't give you direct values off of this because it hasn't been created yet. Okay.
All right.
So now let's go to some examples. Okay. And so here's a case that I talked about last time. Anterior head translation is in the high 30s. So it doesn't really meet our cutoff yet of over 50 millimeters. But this is why we have multiple measurements and we look at different values. So he's in the high 30s. So if I'm looking at that alone, I think, okay, I could use a cervical dental roll. His curve is like 35 degrees, right? So he's got a little bit of a reduced curve. You're thinking potentially a cervical dental roll. But, that would be neglecting looking at these two values because his T1 relative to vertical is above 40 degrees, right? So let me draw that. So T1 is right here, okay? So hallucinate that this is a vertical line up, okay? You guys can still hear me? Sorry.
Yep, I could hear. I was muting myself. Yeah.
Okay, sorry, I thought my headphone cut out there. So T1, here's that posterior tangent line to T1, okay? So I think everybody can see that's about a 45-degree angle. Here's one of those cases where I can't see the manubrium sternum very well. I can kind of make out some collarbones here, so I'm going to guess that it's about here, right? So my line goes back behind T1, and then I connect the top of T1 to that manubrium sternum, and you guys can see that's 80s to 90 degrees. It's a high pizza angle, right? So based off of a high vertical T1 and a high pizza angle, large anterior head translation, this patient has a primary thoracic problem or thoracic hyperkyphosis, okay? But his treating doc at the time, before this patient saw me, didn't know that necessarily, and so the doc put him on a cervical dental roll. So I want to show you guys the curve correction using a cervical dental roll. So he did a cervical dental roll for about 2 years before I saw this patient. So here's pre, here's post, okay? If we look at nothing but cervical curve, again, the cervical dental rule worked. The curve improved beautifully, right? It goes from 33 to 43 degrees. So you're saying, Doc, well, what's the problem? That looks great. But if we look at some other parameters here, his anterior head translation was 35. It's 36. So it's actually, still really forward, if not a little bit worse. If I come down here and I look at the T1 relative to vertical, it's actually even steeper now. And this x-ray is good because you can really see that upper thoracic spine, right? And so you can see how rounded and how kyphotic this patient is. And so, although we improved the cervical curve, we didn't do anything to improve the fact that this patient is extremely hyperkyphotic, has a lot of subluxation problems in the thoracic spine driving his head forward. So now I start seeing this patient, and so I put him on a thoracic dental roll. And here are the different thoracic dental roll products, okay? You have the retrainer. This is kind of like in order of which ones are harder, from easiest to hardest. So the retrainer is kind of like the training wheels version or the easiest version. Then you have the actual thoracic dental roll, and then you have the posture regainer, which is this big unit here that is really good for what I call that teenage slouchy posture. So this is what I use on my, tall, thin, rounded shoulders, head forward teenagers and young adults. So I put this patient on the thoracic dental roll itself for a few months, and here's what his spine looked like after. So here's when he started